Hi, I'm Dr. Hudson Nakamura. I am the retina specialist, ophthalmologist from Brazil. Thank you very much for participating with us in another Retinawesome event. We learn a lot with each other in different countries with different techniques, different retina surgeries and the ways we do, and hope you discuss the cases with us and participate. It's awesome to be with you. Thank you very much.
My financial disclosures is only relevant in that I'm a consultant to Alcon and Bausch & Lomb, but in Bausch & Lomb's case, only their pharmaceutical division, not their surgical division. So we all know how to do macular holes, and the success rates of macular holes have become better and better over time. We're up in the higher than 95% rate. In some years, we're up around 100%, especially using some of the techniques we do currently. But what I'm talking about today is these complicated macular holes. And I really just, put them into three different categories: large holes, large and chronic holes, recurrent holes, so holes where the surgery wasn't successful, and finally macular holes and very high myopes. These are all much more difficult. You have to use different techniques to close these holes. So the first are large holes. So large holes, by definition, more than 400 microns in smallest width, not greatest width, it's smallest width. As in this case here, this is 516 microns at the smallest width or aperture of the macular hole. And if you look at studies, holes that are larger than 400 microns, the success rate is significantly different than those that are smaller than 400 microns. This is a study we did at the Cleveland Clinic where the closure rate was only 75% in these larger holes. Now, this is an older study. We need to actually redo this study with some of the newer techniques, but there was at the time a significant difference in closure rates based on hole size. So really, what has come to fix these large holes? Well, the key sort of trick is the ILM Flap, and this was described a few years back, but the way I do an ILM Flap may be a little different than it was first described. So first of all, I like to have the ILM Flap temporally. So I like to make the edges so it's temporal. And the reason for that is when you do an air fluid exchange with a temporal flap, just the physics of the fluid coming across the hole pulls the ILM flap over the hole. So you don't need to actually do any manipulation of the flap. It just covers the hole after you go to air. I don't do some of the things that I've seen videos of where people stuff the ILM flap into the hole, or do it from all the different sides, temporal, nasal, superior, inferior, and just like cover the hole like they call it like a rose petal. I don't agree with that. The whole goal of the ILM flap is to give you a scaffolding to cover the hole, as shown in this video that Carl O made, to allow the edges to reapproximate, so that you do not need to stuff it in. And in fact, if you stuff it in, you're making almost like a plug to help to prevent the hole from closing. So in Carl's case here, he covers the hole. I would have peeled the edges to make it more of a sort of like a pie shaped from the hole. And the other thing he didn't do, which I do in this video, is I peel all the other ILM edges also. So in this video, he only peeled the flap. I personally peel the flap as shown here very nicely, covering the hole. But I also peel the ILM on all the other sides. I don't leave it like Carl did in this video. But I like the schematics, so that's why I use this video. Using this ILM flap technique, the hole closure rates have dramatically increased in historically as well as in the published literature. And so it's coming close to sort of what we get with smaller holes in terms of closure rates. And it also works very well, obviously, for myopic holes, which we'll cover in a moment. But this is a very good technique. Some people have advocated, especially in cases of previous surgery, using a free flap. The problem with the free flap is it moves too much, and so it's difficult to prevent it from moving when you go to air. Some people advocate leaving PFO in the eye to do that. I don't agree with that, not in a macular hole case. And I think some of the other techniques that I'll show you are actually better. As I mentioned, I don't like the idea of stuffing the ILM into the hole. It's sort of like when we used to use autologous serum in the past. That would cause a glial plug and prevent the hole from closing. You want that whole area to close nicely. But here's a case of an ILM flap. It was done under PFO, and obviously you can see the ILM had been peeled previously. This is a recurrent hole. But for me, I like to use a different technique, which we'll talk about in a moment. But the goal here is, as you can see, is they're just stuffing the ILM into the hole. And as I mentioned, I'm not a big fan of this technique. I use a very different technique than this. I think this leads to too many, anatomically it looks good, but from a visual standpoint, it doesn't work. So the other sort of way to treat a very large macular hole, and when I say very large, these are more than 1,000 microns or very chronic, is a technique that was developed by Tamer, which is a full thickness retinal patch graft. And some of the tips to doing this are, first of all, you need to use small gauge, but you need to use valve cannulas because it's very important to really control the flow while you're doing this. You don't want high flow states. It's really absolutely necessary to make sure that all the ILM has been completely peeled, so that you should use a stain to do that. Most people will do is either a cautery or endolaser from the donor site. I personally use endolaser, and I do use cautery for large vessels in the donor site. In the video I'm going to show you, I did not inject BSS under the donor site, but since I started doing this now, I do use the 41 gauge cannula to subretinally elevate the donor site before I cut it. And then I put the PFO in later. I do use a vertical scissors to make the patch graft because I find that to be very precise to really make a nice circular area just slightly larger than the site that you're going into. So the donor should be just slightly larger. And I think the really important thing is this. Some people try to do this without PFO in the eye. You really need to do this with PFO covering the donor site. If you don't do this, basically the donor very difficult to peel and place into the chronic hole site. So just showing you, here's the case. I like to do it with a chandelier. You can see the chandelier there. Oops, what happened there? Let me get my picture back. There we go. So you can see the chandelier here. This was a high myope. You can see how long the eye is. So endolaser, the donor site, place in this case, this is an earlier case, placing the PFO. Here you can see the PFO being placed, and it's pretty full PFO. Then making the donor graft here using a vertical scissors, which makes it a lot easier. I find I've since changed to doing this part without the PFO in the eye because it's a little harder. But this particular portion where you're peeling the flap and placing it in a hole, that has to be done under PFO. So you can't do this without PFO and then just kind of placing the graft in the donor site. So and then going to air. I personally like to use C3F8, but others have advocated leaving PFO in. And here you can see it afterwards, using silicone oil or gas. And I personally like gas. That's what I use myself. Here's just some examples. This is actually from a talk by Steve Charles. The thing that a lot of people ask is anatomically, these cases look really, really good, right? So these are very large chronic holes. And you look at the OCT and you go, wow, that looks amazing. I don't think visually It's as amazing the results as it is anatomically. Some people have said that the graft recapitulates and there's some connections between the graft and the original retina, but I don't think that's actually true. Now, there is some improvement in vision because the size of the hole has gotten smaller from the patch graft, but I disagree that the visual acuity results in these cases aren't spectacular. It's more anatomic. As I said, I use C3F8. In this case that Steve was part of, the majority were silicone oil. I think C3F8 actually works better than oil for these cases, and I don't ever use PFO, leaving PFO in the eye. But the success rate in these incredibly large holes in this case series was actually pretty good. 90% success rate, and these are very large holes. So it does seem to benefit. Recurrent holes, there's sort of the recurrence rate has been in the literature anywhere from 3 to about 10%. And this is especially high recurrence rate if you do cataract surgery after macular hole surgery. I personally, for my primary holes, always do it as combination. I do have a cataract surgeon come in, do the cataract surgery, I do the macular hole surgery, so it's at the same time. But if you do cataract surgery after macular hole surgery, maybe a year after, you got to be very careful about CME. So you tell your cataract surgeon to make sure to use non-steroidals to prevent this from occurring. So what are the tips for a recurrent hole? Well, the key thing is to see what happens. So most of the recurrent holes that I have to treat are not from myself. They were sent in. And so I don't really know what the previous surgeon did. So I do a very good ILM stain to figure out what they did. If the ILM peel wasn't too large, I'll show you a flap technique. If the ILM peel was huge, they went all the way out to the arcades, the first surgery, then it's very difficult to make an ILM flap in that condition. And so what I've started to do, which has been very successful, is to create submacular blebs. So I use a 41 gauge cannula in 4 quadrants around the macular hole to basically make the hole mobile. And when I first saw this technique, I said, there's no way this is going to work. I don't understand really why it would work, except to allow the hole to become more mobile. But lo and behold, especially these recurrent holes where there's no way to make an ILM flap, it actually works very, very well. So, it's just similar to a translocation or subretinal surgery. You just use 41 gauge cannulas. The reason you have to make 4 of them is because, as you're injecting fluid in one quadrant, eventually it'll make it all the way to the hole and the fluid will just come out the hole. That's when you need to move to the next quadrant to start the next quadrant. You really want to kind of mobilize as much of the retina around the hole as possible. And because the fluid will tend to go towards the hole, you don't have to worry about making some large submacular detachment. It won't get that large. The other thing is if the ILM flap that was performed already wasn't very large, you can actually make another temporal ILM flap where the hinge isn't at the hole, the hinge is at the edge of where the ILM was peeled. The key feature of that is the distance between the hole to the edge of the ILM flap. You need to make the flap itself larger than that distance so that the flap covers both the previous ILM peel as well as the macular hole. And it's actually easier to do than it is to describe. You do need a good staining of this area, and the ILM is thin in this area, so it is a little difficult, but it actually works very nicely. And if it doesn't work, then just go ahead and use the subretinal bleb technique also, or in some cases I use both, either one. High myops is the other difficult one because of posterior staphyloma, very thin and RPE atrophy, thin choroid, very RPE atrophy makes it difficult to oftentimes see. Need a good stain. And very high myops, it's sometimes hard to even do the peel because you can't actually reach the retina. One of the tips and tricks I use for that is you just take the cannula out. Because if you take the cannula out, you get an extra 2.5 millimeters of play to actually get into onto the retinal surface. But these are the cases I'm talking about. Patients with a high myope, they may have a foveal detachment associated with it. And in this case, the idea is to produce a macular buckle. You need to do something to push the posterior staphyloma up to help close that hole and close that little foveal detachment. So one of these techniques that I developed about 15 years ago was to use a sort of temporary macular buckle by injecting a viscoelastic behind the eye, right underneath the macula. I did this originally under intraop OCT guidance, but I find that you really don't need to do that anymore. I've also, in some cases, there's a filler that our plastic surgeons use that lasts longer than Helon does, for instance. And so in some cases where there's a very large staphyloma, I'll use the plastic surgeon's filler behind the macula. But this just shows you, some of the post-op day one. You can see how that posterior staphyloma is being pushed forward by the Helon behind the macula, and that helps close the hole. Obviously, in these cases, we peeled and also did an ILM flap. But in many cases, you have to add this additional posterior buckle effect to let these things close. So, I've showed you many different techniques to use in these very complicated holes. Hopefully, some of them will help you with the cases. But I was asked to present a case for the panel to discuss, and so I wanted to show you this case. This is a patient who had a macular hole from trauma. So they were hit in the eye at a major league baseball game. A foul ball hit them in the eye. So you can see the choroidal rupture there. And the choroidal rupture, as well as the trauma, led to a traumatic hole and then a second hole right next to it. So I'm curious to hear how the panel would recommend we fix this.
Wow, this is a double macular hole. It's pretty interesting. And maybe the first idea would be just to put a PFC because actually we cannot cut the structure. And maybe after trimming the internal, all the attachments over the hole and then leaving that central area intact, if you go peeling from peripheral to central, and then I think if you get to remove the ILM, I think both sides could close because actually the right side is half closed. So I wouldn't do anything but try peeling the ILM very carefully over those areas.
Yeah. Anyone else? That's a great idea. You definitely want to peel the ILM, but I agree with not peeling the ILM in that little area between the two holes. That would be a little dangerous.
That's great stuff that I've looked at. It's almost everything that I've seen all around the world, and you just saw it in a few minutes. So congratulations for a beautiful presentation. For this particular case, I would do two surgeries. I was destined to do two surgeries. The first one will be to buckle and close with tamponade the remnant, the central remnant with the right one. As I look at it, because they have a very small area to work. And then when I finish that and they get closed and I forget the other one, and then when I finish that after a few after further time, I would go for the second one to peel the ILM on the left side and cover it up with the way you do. And I would do it in one hand because you might traumatize it more and you might end up in trouble with that. It's my idea of that.
Yeah, that's a great idea. Well, I'll keep you out of your suspense. So what I did was basically I flapped where the flap edge was on the temporal hole, which wasn't the true macular hole. The foveal hole, we'll call it, was the true hole. The second one was due to the choroidal rupture site there. You can see that the ILM has not really been peeled between the two holes, but on the edges of the foveal hole, I've completely peeled it. And this is almost like what I do in the recurrent holes, where the ILM flap has to cover both the ILM peel as well as the hole. In this case, the ILM flap is large enough to cover both the hole. Both holes are covered by the ILM flap, and so that's what we did, covering up both. And here it is pre-op, and here it is post-op, where you can still see the choroidal rupture, but both holes were closed. So vision improved some, not great because of the trauma and the choroidal rupture, but 2200, I was pretty happy with the result. So. I hope you guys enjoyed a whirlwind tour of complicated macular hole surgery.
This was really, really nice. Saad did a retinal fellowship with me back in Toronto years ago. He's a very good friend of mine. Saad, would you like to comment on Dr. Peter Kaiser's case?
Sure. First of all, it's great to see you, Peter. And this was a great presentation. You've covered, most of these stuff we might see with macular hole. And I think that last case is amazing. I've never seen a patient with such a complicated macular hole. But at least now we know when we get complicated holes, where do we send them? So thank you.
No, you don't have to send it to me.
And Mohammed, I've seen nice cases from you and in many media sources like Instagram. And I know you are very familiar with Mac holes. And could you comment on those cases?
First of all, it's a great honor for me to be among all of these professors. Thanks, Dr. Peter, for your great presentation. For me, I will deal this such a cases as a two double macular hole. Every single hole I will cover it by a different modalities. Like if I have the main hole of the main foveal hole, I will cover with a nasal ILM flap, and the temporal hole I will cover it with temporal flap. If I succeeded for this, I will do this. If I fail, I cover the one of them with any batch of flap surgery or batch surgery. Like if I succeed for the main hole with the ILM flap, it's okay. The temporal one, I can get a retinal graft. So I deal with two different holes as a two different cases, like we have a two holes. So intraoperatively, so we will see if we have succeed for ILM flap, go ahead. If we will not succeed, we will research for any flap. Any material cover this hole, both of them here. So it's a great case, by the way, first for me to see this this large double hole in the same case.
Sasamoto, Marcelo, my friend. And a nice case.
Thank you.
And I would like to comment. How is the time in Bolivia? Everything is all right in Santa Cruz?
Everything is all right. Yes. There's no conflict at the moment, so we are pretty in peace. Congratulations, Dr. Kaiser, for your case. One of my questions is, did you think of performing some relaxing incisions around the macula is another option to close? I don't know if you had experience to made it. Also in high myopes, you perform sometimes relaxing incisions. So what's your experience about that?
Yeah, so I like using relaxing incisions, especially in recurrent holes and chronic holes. And by relaxing incisions, I mean just make some sort of nicks in the edges of the hole, just in case there's like an annulus, a ring of scar tissue around some of these chronic holes. So by just cutting the edges, you can break up that ring to help the hole close. In this case, it wasn't actually that old. The hole, it was more traumatic. Even though the choroidal rupture looked relatively old, we probably operated only about a month or so after the trauma had occurred. So in this case, I just did the ILM peel, and I did a very big and a very aggressive ILM peel, as you saw. But I did not nick the edges. But I think that's a good idea. especially in chronic holes. So I do use that technique. And again, none of these techniques are mutually exclusive. You combine what you need to do to close these holes. And some eyes you have. It's sort of like I tell my fellows with diabetics. The eye gives you what it wants to use to. You just need to know the different techniques and decide which technique you're going to use on that particular hole, because not every hole all the techniques work.
I like a lot doing the inverted ILM flap. Oftentimes, I use the PFC as a tool not to let the ILM escape. And sometimes that happens and I have to move it back again if you plan to do the stuffing technique. But when I peel from temporal to towards the hole, the ILM, you just insert it and you keep a stalk in the periphery, so it never comes out. And I like using the PFC, and it gets the ILM more stable. Some people don't like it, but when you get the ILM, the PFC waves in on the retina, and it keeps it stable there in case you just let it escape and you just get it back. It works pretty well. And what do you think about it?
No, I agree. Like I showed you with Oswald's video, having a PFO definitely makes the movement of the flap much more controlled, and so because of that, it's easier. And I agree. In these recurrent holes, PFO can sometimes be very, very, very useful. I think one of the things like in Carlo's video, I don't make the ILM flap that way. I actually first make the edges, so I peel from the hole to the periphery. So I have edges, so it's sort of the edges are made, and then I peel that last part over the hole. And now because I have the edges already made, then I can peel all the way around the rest of the hole now. In Carl's case, he did not do that, and I disagree with that. I personally peel the rest. So the only area that's not peeled is the temporal area where the flap is. I find that works actually better on these large holes.
Okay. Natarajan, are you around? You want to comment on Dr. Peter Kaiser's cases? And if not, Vibhab, because I know you have another meeting going on, and you are going to present some related cases concerning macular holes. Would you like to comment before you present your case?
Yes, wonderful presentation, Dr. Kaiser. It was lovely to see the double hole case as well, and never seen that before. Just a question, when you do that retinal tissue transplantation, do you place the patch graft over the hole, or do you kind of tuck it inside the hole? And what is the technique if you're placing it over the hole so it stays there? What is the tip for that?
So I do place it in the hole because you're correct. If you place it over the hole, it's going to move. In that case, you have to leave the PFO in the eye if you're going to place it over. Otherwise, it will move. So that's why I make the donor just slightly larger than the hole, and that way the edges kind of go underneath the hole, and the edges hold the donor underneath the hole because I take the PFO out and go to gas. And obviously you want to do that incredibly slowly with a very, very low vacuum to avoid disrupting the donor. But yeah, so it's just slightly larger. It's not a lot larger. And you place it underneath the edges.
Okay, Vibhab. And thank you again for all your comments, Dr. Peter Kaiser. We are always learning how to do the best thing for mac holes, especially those, the large macular holes. And what is your experience in amniotic membranes?
Yes, so I personally haven't used amniotic membranes. I've seen people use it. I think it works very well. The issue, of course, is sort of like an ILM free flap. It's making the amniotic membrane stay. You want it to stay over the hole. Again, I don't like stuffing things into holes. So because of that, you're just basically laying the amniotic membrane, and you need to use something to keep it there. And so most people will use like PFO or do a PFO silicon oil exchange to try and prevent the amniotic membrane graft from moving from over the hole. To me, it's just an extra expense. ILM is free. I just got to use it from the eye that I'm already using it from, so that's free. So in general, I don't use the amniotic membrane. I use ILM.
All right, it gets free. And if we get, this is your subject, we all know that you are very keen at those studies, but if you think genetically, thinking, if you want to align the RPE, the whole structure of the macular hole, do you think in the near future, or maybe longer, we could think of injecting something below the ILM, for example, and not just creating the scaffold for the hole to get closed, but the whole structure to align, such as the RPE gets everything aligned? Do you think there's anything thinking about this regeneration in the near future?
I mean, it's possible. There's others have thought about using is if there's something almost like a tissue sealant that you can put over it. So if you go to air first and then put a tissue sealant over, has been tried. But all these techniques, especially the tissue sealant, some of the tissue sealant gets into the hole, and if that occurs again, that's sort of like a plug. So it's hard to say what some of these newer techniques you described, if they're going to work or not. I'm not sure.
Okay, thank you very much again for teaching us and sharing with us and discussing with us these cases. And this was really a gift for our audience here, and also your lecture will be in our channel so that we could discuss more.